Yeah. And who do you think is appropriate to select for a delayed, a trial of rehab, prehab, etc.?
So, as I've already mentioned, I'm more than happy, unless they've got one of those things that we've spoken about already, to have a minimum of 6 weeks of physiotherapy. So from my point of view, I'm not rushing in and doing an ACL reconstruction on just anyone and everyone because I can. I've got the evidence to back that up. And so those people that we're looking at delayed or planned are those people who have got a functionally stable knee, who are in that adapter or that coper group that can modify what they do for a period of time. And we do know that, people who are involved in heavy labour industries, can modify their job activities for a period of time until they get their knees to where they need to be and then can go back.
Yeah.
So from that point of view, those people who are also getting into the twilight of their sporting career or are happy to adapt what they do, so rather than playing footy, jumping onto a bike, or doing some straight line running. So again, it's having a discussion with the patient, trying to figure out what and where to go.
Yeah. And obviously, as we've talked about, patient choice is also paramount in this, in that some people will just be absolutely adamant that they want surgery, or absolutely adamant they don't want surgery.
And you have to accede to their wishes to a point. And there are definitely people out there that are not going to go well without surgery. And generally we know who those people are. And so we push them down that surgical route right from the get-go.
And from the physio perspective, I also see that people who come in and they've got a very swollen knee and they don't have good quads activation, they have poor leg control, they have a poor gait pattern, those sorts of people do better, I think, with surgery if they have prehab first and resolve all of those impairments and come to you with a knee that is
and the research shows
more functional.
That if they have an absence of fusion, if their range of movement arbitrarily is within 20 degrees of the other side, if their strength is within a percentage difference of whatever you wish to take it to be, you can then operate on them. We do know that if we rush straight in and operate on those people who are not quite back, they do struggle a little bit on the other side. And I always tell people, putting in 6 weeks of prehabilitation will probably save you 6 weeks on the other side of it. So, and then they compute that and then go, I'll do that, and then have a look.
And obviously, as we've discussed, there are people with different life situations and occupational, family demands, all of those sorts of things. I suppose the other group that I see is people who have other medical complications. So recently I've had somebody who's had a DVT, and obviously they're not appropriate for surgery, so they've had to, they do want surgery, but they've had to delay it until the haematologists are happy.
Absolutely.
So there's those sorts of medical, and I think, as you've mentioned before, anybody who's uncertain about their pathway, as long as they're rehabbing safely, they're certainly giving themselves a chance to either continue on that non-operative pathway, or if they require a delayed surgery, as long as they don't do too much secondary damage in the meantime, the outcomes of that surgery.
And that's one question they ask is, can I do any further damage? And the answer is always yes, depending on what you're doing. And you're not burning a bridge by not rushing into surgery. And I always tell patients, your knee is not going to knock you off your perch, but something else might. And we've got to get that addressed before we operate on your knees. And
I often show patients this slide, which just summarises the group, so that if you're thinking about the decision making, non-operative tends to be older, minimal pivoting or happy to modify it, functional knee stability or playing recreational sports, if they have success with prehab, and then an isolated ACL injury, whereas the operative group tend to be the younger, pivoting, or wanting to be unrestricted, or they have instability, playing competitive or elite or professional sports. If they've failed prehab or have a complex knee injury with other concomitant injuries.
One of the things I get asked or told a lot is, I don't want to think about my knee, sort it out.